Welcome to the conference session titled Understanding PNH. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window. When you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Today's specialist is Allison Pishko. Dr. Pishko is an associate professor of medicine at the Hospital of the University of Pennsylvania. She earned her Bachelor's of Science in 2008 from Notre Dame, her medical degree in 2012 from the University of Pittsburgh School of Medicine, and her Master's of Clinical Epidemiology in 2018 from the University of Pennsylvania. She completed her residency at Duke University Medical Center and her fellowship at the Hospital of the University of Pennsylvania. She is board certified in hematology, internal medicine, and medical oncology. With all of that said, it is my extreme pleasure to welcome Dr. Pishko. Thank you so much for joining us today, and you can share your screen for your presentation at any time.
Okay, I'm gonna, just everyone hears me okay. Thank you so much for that kind introduction. It is such an honor to be able to present to this crowd today. Just like the introduction mentioned, I'm Dr. Pishko. I'm one of the non-malignant hematologists at the University of Pennsylvania in Philadelphia here. Here are my disclosures. And so for today's talk, we're going to focus on PNH. And so this is going to be a pretty basic overview, and there will be lots of time to take questions at the end. And first, we're going to start off with just the how. How does PNH happen? What kind of goes wrong to cause this disease? And then why? What do we know about who is at risk for developing PNH? We'll briefly touch upon the diagnosis of PNH. How do we determine who has this disease? We'll also go over some signs and symptoms of PNH. So I know many of you will be familiar with this, but what does it mean when we say people have a hemolytic anemia? What is the typical thrombosis that can occur? And then we'll also briefly touch upon the treatment options for PNH. So PNH has paroxysmal nocturnal hemoglobinuria. So with this mouthful diagnosis, it always helps to break it down first, word by word. So starting off with paroxysmal. So paroxysmal is referring to the sudden onset of symptoms. So often patients will have kind of intermittent attacks of this disease. Nocturnal is just referring to that for a reason that's not that well understood, actually, that symptoms often increase at night. And so patients will often notice this dark urine, particularly when they wake up after a night's sleep. And that brings us to the third part, this hemoglobinuria, which is referring to the presence of blood in the urine, or specifically breakdown products from the red blood cells. And so together we get this diagnosis of paroxysmal nocturnal hemoglobinuria, or PNH. And so PNH is a disease mostly in adults. can be a difficult diagnosis to make. And so we do believe cases may be underreported, but it's estimated to be 1 to 10 cases per million adults. And it does affect both genders. So both males and females can be affected by this disease. And so how does PNH occur? Well, it first helps to kind of understand, basic blood tests that are done. And we look at a complete blood count. And so whenever you see a result of a complete blood count, you're going to see a couple of things reported. So you'll see what are your white blood cells. And the white blood cells, there's a number of different white blood cells, but they're all involved in kind of fighting off infections, different types of infections. Neutrophils will go after bacteria. You might have eosinophils, which will go after parasites. And then you have your platelets, which are involved whenever you get a cut that you need to kind of stop it from bleeding. Your platelets are kind of the first ones to the scene. And then what's a really key part of PNH is the role of red blood cells. So what are the red blood cells? Red blood cells are really the body's oxygen carrying cells. And so, you breathe oxygen in from the lungs, and then you need something to be able to go and distribute that oxygen to the tissues that actually need the oxygen. And so inside of each red blood cell is this molecule that's very rich in iron, and it's called hemoglobin. And so hemoglobin is what actually binds that oxygen to be able to deliver it to the tissues in the blood. So it's really, really important. As we all know, oxygen is important to life here. And so whenever we are trying to measure the hemoglobin, you'll see two things that are typically reported on your blood counts. You'll see a measure called hemoglobin, which are sometimes abbreviated HGB. And that's the volume of the protein hemoglobin. And then the hematocrit, which they're related measures, but it's the percentage by volume of the red cells there. And we know that there are certain kind of normal ranges that keep you from being short of breath or fatigued. And we know that if low hemoglobin and hematocrit, really low levels, can impair oxygen delivery to the tissues. And so if your hemoglobin is low, below a threshold, a certain threshold, which may vary a little bit by individual, but generally less than 7, patients may need blood transfusions to be able to do their daily activities without feeling short of breath. And so all of these red blood cells, so this vital cell, and actually all of the blood cells that we talked about on that complete blood count, the white blood cells, the platelets, they all come from the bone marrow. And inside the bone marrow are these stem cells that kind of start off in this factory and then mature in the bone marrow until they go out into the circulation and do their ultimate job. And so the bone marrow is where all of these cells differentiate and kind of grow up. And it's really amazing, the body, the average person is going to make 2 to 3 million blood cells per second, which is crazy. So your bone marrow is constantly pumping out new cells. And on the surface of red blood cells, they have certain markers, and we use these markers to kind of define the cells. And you'll hear us talking about kind of naming these surface markers by what's called a cluster of differentiation, or a CD system. So each of these markers will have a certain name. And so 2 of them that you'll hear us talking about in PNH are CD55 and CD59. And so it's also important to know that we have this complement system. So I mentioned that white blood cells are used to help and fight off infection. Well, you also have complement, which is its role is supposed to be, so say you're infected with a bacteria, the complement should go and try to tag the bacteria and deposit on that bacteria so that it is ultimately destroyed by the immune system. Now, the immune system needs a way of knowing, well, what's a bacteria that I should go after and attack? And what is something that is self or is part of the body and I shouldn't go and attack? And one of the things that is on a red blood cell surface that says complement, don't deposit here, are the cell surface markers, the CD55 and CD59. And so part of the what is the problem in PNH is there is a mutation in the stem cells in the bone marrow, again, where all of the red cells will form from, that causes these red cells to lose their expression of CD55 and CD59. And so this mutation is the PIGA mutation. So this is not generally something that someone is born with, but is something that is acquired or happens over time. And so when this mutation is present, there'll be a population of cells coming out of the bone marrow that will no longer have this basically self-defense marker that says immune system, ignore me, I'm supposed to be here, I'm part of the body. They lose this expression of the CD55 and the CD59. So without these markers on the surface, then the complement system doesn't know to ignore these red cells, and you'll get complement deposition, or it will kind of trigger a system whereby the red cells then burst or lyse. And so they've lost that protective mechanism and they start to be destroyed, just like your body would go and see a bacteria and want to destroy that. And so how do we diagnose PNH? How do we know that this is happening? Well, we can actually measure the number of red cells, or the percentage of the red cells in the body that have actually lost this signal. So you're saying, of all of the cells that we see circulating around in the body, just what percentage of them have come from that defective stem cell that causes them to lose the CD55 and CD59? So you'll often hear people talk about a PNH clone, or what's the clone size? And that's what that is. That's measuring the number of cells that are there that have lost this basically self-defense mechanism. And so how we do that, the clinical test to be able to measure that, is something called flow cytometry. And so with flow cytometry, you're using a machine where these cells are kind of just, think of it flowing through a funnel there. And each cell will kind of have a certain type of scatter to it. And you're able to tell what is on the cell that should be there or shouldn't be there. And you can see that some of the red cells, what you identify on the flow cytometry as a red cell, are missing these certain red cell specific cell markers. And so this PNH flow cytometry is again measuring that clone size. And so why does this happen? So that is a really important question that is the subject of a lot of research. We do know that these are acquired, generally not inherited, not something from your mother or father. Interestingly, that we haven't identified clearly, clear risk factors for developing this mutation. We do know that, really interestingly, that these clones are closely associated with other immune disorders. So one of those, which I know will be a subject of other talks, is aplastic anemia. And so that aplastic anemia is when you have your immune system going after those stem cells in the bone marrow, and it can cause some really severe cytopenias or low blood counts. And the PNH is often also seen with aplastic anemias. And sometimes these clones can be found incidentally. So sometimes we're working up patients for other things, or thinking about other causes of maybe like a blood clot, or sometimes even in asymptomatic folks, that we can see small clones. And again, we don't know why some of these clones will cause problems and some of them won't. We do think the bigger the size, so the larger number of percentage of cells that do lack the CD55 and 59 will cause more symptoms. But the why, the what makes an individual develop this, that's really, unanswered, and lots of questions remain. So what are some signs and symptoms of this? So what happens when you lose these expressions on the red cells? Well, so people will be familiar with this term, I believe, of hemolysis. So what do we mean by hemolysis? So that's really the red cell bursting. And how do we know the red cell is bursting? Well, there are some other labs that you can draw that are kind of indicative that this is going on. And so these are labs that will be followed with someone after they are diagnosed with PNH. Sometimes they are the lab that gets people thinking about this diagnosis. And that is that elevated LDH, or lactate dehydrogenase. So when the cell is exploding, this LDH goes up. And then interestingly, another lab is called the haptoglobin, and we will see the haptoglobin go low. We will also see that the red cell, because of these products are being released into the system, where we can see some of the breakdown products is actually in the urine. And so that is when we can get this dark or black colored urine present. We will also, another sign of PNH can be difficulty with swallowing. So this is a really interesting phenomenon that actually, when you get the hemolysis or the breakdown of red cells, you also consume nitric oxide. And so without nitric oxide, you have problems with the smooth muscles. So smooth muscles are often in the esophagus, where you will not be able to swallow properly. And again, that is a side effect from this breakdown of red cells and the use of nitric oxide there. As far as other, one of the things that I commonly see, I specialize in thrombosis or thrombotic disorders, is clotting. And so some of the 8 clotting features that we can see in patients with PNH are clots in unusual places. And so what do I mean by that? Well, the more common place to get a blood clot is where blood flow is particularly slow, and that often can be like the lower extremities are in the legs. So one of the most common places that in people without PNH that we will see blood clots would be a deep vein thrombosis in the leg, and some of those times those can go and become a pulmonary embolism. Interestingly, one of the features of PNH is blood clots can happen in more rare locations. So we certainly see these blood clots in other diseases, but their presence, it does make us definitely think about this diagnosis. So what are some of those places? Well, one of the places is in the brain. So you have the blood-brain barrier, meaning that the blood in the brain is very separated from the rest of your body. And you have this system whereby the blood and the CSF kind of drain from specifically the brain. And so patients can experience clots there, and sometimes that would present as a severe headache. Sometimes there can be bleeding. That's a cerebral vein thrombosis. We also can see blood clots in some of the organs. So abdominal blood clots can be present as well. And often it's these atypical blood clots that may be the first presentation of PNH, and exactly what we're trying to prevent by treating the PNH. We also know that PNH itself can cause fatigue. Some of that fatigue can be related to the very low hemoglobin. Recall that I mentioned you're going to get these breakdown of the red cells, and that the hemoglobin can drop. And whenever the hemoglobin is low, for a lot of people, that can cause a pretty profound fatigue. We know too, also with the one can be from clotting, but also from that scavenging of the nitric oxide, that patients can also experience some pretty severe abdominal pain with PNH. Sometimes PNH is also associated with other bone marrow dysfunctions or other disorders that kind of decrease the production of other blood cells. We mentioned briefly about aplastic anemia. And so again, that's when the immune system is also attacking the bone marrow. And so with those, we will also see a low white blood cell count, perhaps a low platelet count. So when we think about, kind of classic PNH is really the red cells bursting, but we know that PNH can also cause problems in other cell lines. So in the white counts and in the platelets, particularly when it's associated with other bone marrow disorders. And so a patient certainly doesn't have to have another bone marrow disorder with the PNH, but sometimes these diagnoses go together. So different patients may find that they have different accompanying features with the PNH. And so how do we begin to treat PNH? Well, the first is, recognizing the disorder, and so increasing awareness of what are common signs and symptoms of PNH to look out for. Recognition is really key, and it's so important to be able to diagnose this disease, because fortunately we do have treatments for PNH that can really prevent thrombosis and make this from what can be a very dangerous and life-threatening disease to one that people can certainly manage. And so we're very excited that we now have multiple treatments for PNH. So how do the PNH treatments, how do these work? Well, I mentioned earlier that the problem with PNH is that you have this loss of this basically sign to say, immune system, leave me alone. And so it's a problem where you're going to get too much complement deposition or too much deposits of this complement, which then creates this attack complex, which goes and causes the red cell to lyse. And so one of the really big advances in PNH was the development of eculizumab. And so what that is, that's the one that came first, is a C5 inhibitor. So we're talking about a specific part of this complement system. Remember, the system that is going after the bacteria, and it's inhibiting that from forming. So by preventing this complement deposition, and again, this is for the body, but it also for every cell in the body, you're inhibiting this C5, but particularly it benefits this disease because then that complement is not depositing on the cells, the red cells, and causes lysis. There's also newer treatments, another C5 inhibitor. So with eculizumab, generally patients are on it's an IV therapy. Started off every 2 weeks. Now there is one that lasts longer, which is a great advance for patients. Another complement inhibitor, ravulizumab, is also available for the treatment of PNH. And again, both similar in that they are preventing this complement deposition on the red cell, so allowing the red cell, even though it doesn't have the protective marker anymore, to be able to survive in circulation and not getting the hemolysis. And again, some of that hemolysis can also not only lower the hemoglobin, but put you at risk for thrombosis and that smooth muscle dysfunction as well. So these complement inhibitors, by preventing the red cell from bursting, also prevent those complications, which is really great. There is also a newer therapy that is out as well, which is a sub-Q therapy, which is the C3 inhibitor as well, which is the newest to the PNH treatment here. What are the some of the risks once you know we have these great therapies for PNH? Well, we know that there is a risk for infection. So remember, I said that we are not only with these medications inhibiting or preventing the deposit of complement on red cells, but you're inhibiting the complement system in general. And so we do worry about infections. But fortunately, with very close monitoring and importantly vaccination, we can prevent serious infection. So one of the really important vital things before starting on a complement inhibitor or once you're initiated on it, making sure you're staying up with your vaccinations, particularly to meningitis. So meningococcal infections, which are causing that meningitis, which people can present with headaches and nausea, vomiting, and fevers. Those organisms that cause meningitis, the bacterial meningitis, our body really fights those with our complement system. So it's really important to stay up to date on those vaccinations. Unfortunately, with vaccination, the incidence of having a severe infection goes way down, which is great and makes these safe and effective therapies. And then using antibiotics might be something that people are on who are thought to be higher risk or weren't able to be vaccinated to try to prevent infections. And so fortunately, we're able to keep the risk of infection down with close monitoring here. What are some other treatments that may be recommended for PNH? Well, I said one of the features and how I often get involved with patients with PNH is about blood clotting. And so with the eculizumab and these other complement inhibitors, we're hopeful, the goal is to decrease the incidence of clotting. But for some patients with the acute clot, meaning like right when the blood clot is diagnosed, it's really high risk time for getting more blood clots. And so often people will also be on a blood thinner. And so a blood thinner is trying to take that clot that formed, wherever it may have formed, be it in the cerebral venous sinus thrombosis or in an abdominal clot, and keep that clot from propagating. And so we use these blood thinners to do just that. And so sometimes patients may be on a blood thinner for a couple of months when they first have a blood clot until they get on a complement inhibitor, or sometimes they may stay on a blood thinner. And so it's always a little bit confusing to say, well, if I'm anemic, why am I on a blood thinner? And it's because these blood thinners are to avoid propagation or extension of clots in certain patients. And then we also know that if patients do not have blood clots and other things that may come with this diagnosis, in some patients, again, not all patients, we can see bone marrow failure, and this could be severe aplastic anemia, meaning that the immune system has really affected those cells, those progenitor cells we talked about that are the factory for making your white blood cells, your platelets, your red cells. And so for some population of patients who have PNH, usually because of these other low blood counts, they may need a bone marrow transplant. And so I would just like to have my reference and acknowledgements here. All right, and I think we will have plenty of time here to take some questions. Just share here.
Hi, Dr. Pishkos. Thank you so much for the presentation. Our first question is, how is aplastic anemia connected for PNH? And does that affect the course of treatment for PNH patients?
Yes, that's a really great question. You can have PNH with aplastic anemia. You also may have PNH without aplastic anemia. So they don't have to be together. But with aplastic anemia, why we think PNH is first of all more prevalent in patients who do have aplastic anemia is because of this disordered immune response, meaning that your immune system is in aplastic anemia is not doing what it should, right? Your immune system should know to ignore those cells in your bone marrow and not go after them. And we think because the immune system is not doing what it should, right? It's going after these cells in your bone marrow and aplastic anemia, that immune dysregulation, meaning that your immune system is allowing things to happen that it shouldn't, can actually lead to kind of the expansion of some of these PNH clones. And so that's not for all patients. Some patients will, some of you may just have may have PNH, but some patients have the aplastic anemia. And you're exactly right. So the course does change depending if you have PNH, which is most of your issues are related to the hemolysis or the breakdown of red cells, or if you have PNH, so you have some breakdown of the red cells, but you also have severe bone marrow dysfunction. And what I mean by that severe bone marrow dysfunction can mean that also your infection fighting cells, the white blood cells count is low and the platelets are low as well. Sometimes when people have the aplastic anemia and the PNH, the treatment course can really depend on the severity or just how bad is the aplastic anemia, and how we determine, how bad is the aplastic anemia. Not necessarily by we have like we have kind of criteria for what we're thinking about as far as like your neutrophil count. If the neutrophil count is particularly low, below a certain threshold, you may be a candidate for a bone marrow transplant. And so this, and by bad, I mean just like how dysfunctional is the production of the other cells. And so, yes, the presence of aplastic anemia with PNH could change the treatment course. Patients may be with severe aplastic anemia, it may be something with a bone marrow transplant or using other immunosuppressants. So I mentioned that the issue is with the immune system, and so sometimes there can be medications like cyclosporin or Promacta, where you're trying to decrease the immune system and increase the production of other cells. Did that answer the question?
Absolutely. Thank you so much. Our next question reads, what is a range of PNH cellularity where you would qualify actually having PNH versus saying you have a few PNH clones?
Great question. So we were just talking about kind of the percentages of those cells, and there's not a great kind of firm cutoff. A lot of it has to do with how the patient is presenting clinically. So we do find these small, so what's like a small clone, like a 1-2% clone is certainly a smaller, what we consider like probably a subclinical, meaning, and by subclinical meaning like, yes, we detect it, but it's probably not causing symptoms, versus like, as an example, like half of these cells, 50% of the cells are have this PNH kind of presentation, that would certainly be a clinically significant clone. And so while there's not kind of like a firm cutoff, like certainly smaller, sometimes we see the presence of smaller clones and do say that they, could be clinically significant. Certainly as the size of the clone goes up, you're more likely to have PNH. The presence of a clone too, just to, bring up, sometimes it will also help with determining a diagnosis when there is bone marrow disorders. And so sometimes we're kind of between diagnoses, like, is this an aplastic anemia or is this MDS? And often these, like a presence of a PNH clone being there might kind of take you towards a diagnosis of that aplastic anemia, which is really your immune system's issue. But I don't use like a firm cutoff to say this is, significant or not significant. It's more kind of clinical presentation of the patient as well.
Thank you. With having 3 options now for FDA-approved treatments for PNH, how does a physician and a patient decide which is the best treatment for that patient?
That's a really, really good question. I think it really is a changing field. So even in the time that I have been practicing throughout my fellowship, we've gotten at least one new treatment. Before everyone was on eculizumab, and this was everyone with a significant a PNH clone that was causing issues. And now it's kind of a discussion, I'd say, but about some people feel comfortable continuing on eculizumab because it has been so effective for them. Other patients value the ravulizumab because of a lot of patients are able to space it out longer, and so some patients really value that, not having to have an infusion every 2 weeks. If some patients can space that out up to 8 weeks. And then we have obviously the subcutaneous therapy as well. I think practice is going to change. I'd say in my practice, I'm mostly seeing patients who are presenting with thrombosis and not so much with bone marrow failure, and I'm using either the eculizumab or the Ultomiris medication in the first line. But it is going to be interesting and evolving how kind of some of these new agents come into play. But the good news is that they're very, very effective, which is great.
Thank you. This question comes from a patient who's currently being treated with Ultomiris, and they're having some breakthrough hemolysis. Their physician is suggesting maybe switching to pegozacopaline. What is that transition process for a patient?
Yeah, good, really good question. And that's when we were kind of talking back to like the first question of like what would be reasons to switch therapies. Well, having frequent breakthroughs may be a reason to switch. And part of that new treatment we mentioned, which is the sub-Q treatment, is there's thought to be a benefit to both preventing intracellular and extracellular therapies. As far as the transition, it is going through a different type of therapy. So one, right, is the infusion and then going to a subcutaneous therapy. I personally have not, as someone who kind of not more on the thrombosis, I have not transitioned patients, my own patients yet, over to that therapy. I can't speak on the patient side, like what to kind of expect for that therapy, but I do think it's definitely something to consider when people are transitioning over, and that some of the big changes are going to be kind of the modality of the therapy. I think they all appear to be pretty well tolerated medications that have, a similar mechanism. But what the exciting about this new subcutaneous therapy is that ability to prevent not only the intravascular, but some of this extravascular hemolysis. But I'm sorry, I can't speak on kind of my own patient's experience with transitioning to that therapy quite yet. Probably something we're going to be increasingly using.
Thank you. Our next question is it common for an aplastic anemia patient with less than 1% clone to have their clone grow over time?
And good question. And so, yes, we can see these clones change. So that, it's, as you say, how does that happen, right? So I mentioned that this is the PIGA mutation, right? So there's this one mutation, but why do only some cells kind of come from that one defective stem cell, and why do others not? What determines your clone size? And that's something that's still under kind of investigation, but we do believe that and especially with aplastic anemia, that this dysregulated immune system, the immune system not doing quite what it should, kind of can allow that clone to expand. So we do see clones change over time. So especially with aplastic anemia, where we know the immune system, or I should more specifically say, kind of that immune regulation is not normal. We can see clone size change, and so that's important. Why your physician is probably following that over time.
Thank you. We know that before a PNH patient undergoes a therapy, they need to be vaccinated with meningococcal vaccine. Is this something that requires boosters? And how often does a patient receive the booster?
Good question. Yes. So it is important. So there are a couple different types of meningitis vaccines. Oops, I messed up my camera there. There is the meningococcal. So there's two meningococcal vaccines. Actually, there's more than two, I should say. There's Menactra, Menveo, Bexsero. And yes, you do need the initial vaccine series, and then I always have to look up our vaccine recommendations. But I believe at 5 years, you also become revaccinated for the meningococcal vaccine. So it is important to talk with your physician about, it's not a one-time vaccination. For some of them they are, but not for all of them. So it is important to kind of keep up to date with that. A lot of people also may, because these are very common common vaccines actually in the general population too, some of them, that sometimes patients will also have already received the meningococcal vaccine. Because of sometimes colleges or whatnot will recommend these too. And so yes, you should stay up to date on your meningitis vaccine. But I'm sorry I don't have the table for you here.
Sure. And speaking of vaccines, what is the recommendation regarding the flu vaccine for PNH patients?
Really good. Another really good question. So yes, you should also stay up to date on the influenza vaccine. Again, that's really important, because we do know that patients who are on these complement inhibitors, although we do a really good job at preventing the meningococcal infections, can be at risk for other infections. And so getting all of your annual vaccines is really important. So yes, you should get your influenza vaccine too.
Great, thank you. This question reads, it's very difficult to explain PNH as a patient. What is the best way to explain PNH should I end up in the emergency room, being that the ER doctor may never have seen a PNH patient or may not even be aware of what PNH is? How should I explain my diagnosis?
That is a really, I love that question. That's so important to be able to, take this diagnosis. It is a confusing diagnosis, and you're right that like a lot of people in their career will see many patients with PNH. So I think a good way to explain it, some key words to say is that this is a problem with my red cells where my red cells lyse. And so that term hemolysis, that is a pretty commonly, probably common to everybody on this panel now, but a common, medical phrase. And say my, red cells break down. And that breakdown of red cells can cause me to have blood clots and other problems. And so really focusing on that it's a problem with the red cells, I think could be helpful. The other thing to, potentially relay to, someone not as familiar with the diagnosis is, okay, if I'm telling them that I have a problem with the breakdown of red cells, they may, or I have a problem with too much breakdown of red cells, they may think about other disorders that are more common. And so some things to say that like, no, I do not have, would be some other immune-mediated causes of hemolytic anemia, which are like autoimmune hemolytic anemia. That's a cause, or another cell is like another type of disease is like sickle cell anemia. So you want to say I don't have these disorders. Mine is this breakdown of cells that happens because there's a defect in the cells from my bone marrow. I think using that keyword of hemolysis though would help because it is important for the ER. When I think of what does the emergency room need to know about your case kind of immediately. And one is why is the red blood cell count low? And that is important because the more common causes of a red blood cell being low are going to be bleeding. And so you don't want to sit in the emergency room going through a long workup for bleeding. And so relaying to them, like, no, I'm unlikely to be bleeding. My red cells lyse is a really important thing to relay, and I think could kind of help emergency room providers. I do think, fortunately, there's increasing awareness of this diagnosis. So why I can't say they all, every physician that you'll run into will right away know you'll be very, very familiar with the diagnosis. I do think that awareness is really increasing, which is great.
Thank you so much. That was very thorough an answer. Our next question comes from a PNH patient. They are 10 years post-diagnosis. However, they're beginning the onset of menopause. Should they expect any changes in their diagnosis, or in fact, and more importantly, should I expect any changes in my treatment? How will the onset of menopause affect my diagnosis and treatment?
Good question. So it'd be interested to hear patients' experiences on this, but to my knowledge and my experience, that menopause does not affect the treatment. There could be the treatment or the severity of your symptoms. We do know that, of course, like it may be difficult during menopause if you're feeling hot flashes or feeling fatigued. Trying to distinguish that from breakthrough of PNH. Could be a challenge. That's one thing that I would think about, but I don't think of that those hormonal changes, why they do so much to the body, of necessarily affecting the treatment of PNH.
Thank you. The next question is, I've read that there's an association between Budd-Chiari and PNH. What is the association?
Really good question. So that was related to when we talked about these atypical blood clots. So this is kind of what I do, is the thrombosis world. So what is Budd-Chiari? So Budd-Chiari is clotting in the liver. So it is particularly in the liver. So you have two systems. So you have blood that's flowing into the liver and blood that's flowing out. So the vein, the portal vein goes into the liver, and then you have these hepatic arteries that kind of flow out. And that Budd-Chiari is actually clotting in that liver system. And so often, sometimes that's a rare thing to happen. So PNH is not the only disorder where that happens, but these it is a sign. So like in somebody who comes in with Budd-Chiari and doesn't have any other liver problems, it should trigger for clinicians like thinking about this diagnosis. And why? So why does Budd-Chiari happen in patients with PNH? Well, we know when there is this breakdown of cells and release of consumption of nitric oxide and release of these hemoglobin molecules into the circulation, that it does for some reason trigger what's the coagulation cascade, and your body's tendency to form clot. And it's interesting, we don't really know why the clot forms where it does, but it does. Certainly patients with PNH are more likely to have clots in their hepatic or portal system. And also when I mentioned that they could have clots in the cerebral veins as well. So we're not exactly sure why, but the Budd-Chiari is formed from clots, and those clots formed related to the PNH and that hemolysis itself. Those systems are intertwined.
Thank you. This comes from a patient who is wanting to know, is being on treatment lifelong? Have you ever known or heard of a patient that was able to stop therapy and continues to do well? And if you do stop therapy, is it as effective if you choose to go back on?
Yeah, good question. So I know we're learning more and more about like who needs treatment, and when could treatment be stopped. I would say that most of my experience, my practice, my patients have remained on this type of therapy. Certainly some of the patients that may consider stopping, maybe patients who had another bone marrow disorder, and do they need to continue after treatment of that bone marrow disorder? For instance, with aplastic anemia and PNH, would treatment of the aplastic anemia, kind of resolution of that, and when you aren't detecting the clone anymore, potentially a patient like that may stop therapy. But I can't say I have personal experience with my patients stopping therapy, but not that it wouldn't be something to discuss individually with your physician.
Thank you. How common is the evolution of MDS with PNH?
Good question. So it is something that we monitor patients for, because PNH is a more rare disorder. It's hard to give exact percentages. We do know that PNH is probably underdiagnosed, and sometimes we only start looking for PNH once in some patients in some patients the diagnosis of PNH comes first, right? So some patients, which are most of the patients that I see, come in with a blood clot, and then they are they then go looking for, okay, they have PNH, we found this PNH clone, do they have a bone marrow disorder? But a lot of times it can happen the other way around, meaning that somebody comes in with low blood counts, with low platelets, with low white blood cell counts, and they end up getting a bone marrow biopsy first. So the clotting didn't come first, they did the bone marrow biopsy. And if that bone marrow biopsy looked to be what we call hypocellular, had a decreased number of cells, then they sent off this, PNH flow cytometry and found the PNH clone. And so it's hard to know, not all patients with PNH may even have a bone marrow biopsy to begin with. But when we talk about, myelodysplastic syndrome, that is, a bone marrow disorder. And so certainly we do worry about that in patients who do have a bone marrow disorder to begin with, like aplastic anemia. And there are some features, based on kind of like chromosome tests and different, age of the diagnosis of the aplastic anemia, where we can see evolution to myelodysplastic syndrome. But many patients do not have that happen to them. And I can't, I'm not kind of aware of the exact percentages, but more frequent in patients who do have bone marrow disorders with the PNH.
Thank you. This question comes from an aplastic anemia patient who had a bone marrow transplant 8 years ago. At the time, PNH was not diagnosed. They're now in the process of being diagnosed with PNH. Why would that happen, being that they had a bone marrow transplant for aplastic anemia? And they're wondering, where do they go from here? Do they look to engage in drug therapy, or what would be the risk and benefits of considering another transplant?
Yeah, really interesting. So, I can't, comment on the specifics of your case, but some things to think about is it's really interesting. It is it's a very interesting case where you say, well, what seemed to be the problem was the aplastic anemia, and it was, as far as like severity, severe enough that you needed a bone marrow transplant. But the whole problem is in aplastic anemia is really not just, it's not just the cells in the bone marrow, it's also how the immune system is regulated. And so we unfortunately do know that bone marrow transplants are very effective, but there can be some, basically relapses of the disease. And kind of going towards like, so what is the treatment? When we think about like what patients need bone marrow transplants versus what patients need to be on a complement inhibitor versus what patients just need observation. It really depends on, for me, on what, the prominent or most the largest symptom is. And so if a patient is their blood counts are otherwise doing okay, but their main symptom is this hemolysis or breakdown of the red cells, trouble keeping the hemoglobin up, or clotting, then that takes us more towards PNH treatment. But I think the decision about doing another bone marrow transplant is certainly a complex one. It has to take into consideration a patient's blood counts and also their personal conversations with their physician as well. So not a clear right or wrong answer on that one.
Oh, thank you. This next question comes from a family member. My mom, who is 83, was just diagnosed with PNH. So we're in the early phases. She's concerned about undergoing therapy and the side effects. Do we know how the treatments fare with older patients?
Good. Another really good questions, all from the panel. So PNH is a diagnosis of mostly diagnosed in adults. Yes, we can see it in older in older adults as well. And I would say, fortunately, these therapies can be really well tolerated. So it's certainly not a by any means is this an easy diagnosis. But the main, some of the main side effects of these complement inhibitors like eculizumab are really the infectious risk, which we kind of minimize with using these vaccinations. And then otherwise, I think a lot of people tolerate them quite well. So there could be issues with like infusion reactions, meaning like when the drug is infused, people having kind of like allergic reactions. or feeling fatigued the day they get the infusions. But I have many patients that don't have any really side effects from getting these therapies. So I think it definitely is something that if she's symptomatic, would definitely be considered in her, and not necessarily something that we would withhold based on age alone. Unlike whenever we talk about kind of like chemotherapies or something, sometimes you would have to be careful, because those toxicities of like a chemotherapy could definitely increase. We know, not that we wouldn't treat someone, but chemotherapies can be harder on people as they age. I think these complement inhibitors aren't necessarily the same in that way, that older patients could potentially tolerate these quite well. So that's good news, is that treatment is still an option, which is great.
Thank you. And just to tag on for newly diagnosed patients, do you have some key questions that you think are helpful that newly diagnosed patients should be asking at the time of diagnosis and before they start treatment? Are there some questions you could recommend that would be helpful? And a new diagnosis, you just have no idea what you should be asking.
Yeah, it's just it's a lot. It's something that I think, just as it was like mentioned here, that before this diagnosis, most people would probably never have heard of this disorder. It's certainly not something that someone like their neighbor or would potentially have, and so it is a lot of information to take in at once. So what are key things to ask? So what I'd say, the first thing to ask is, can you explain to me, how we arrived at this diagnosis? What feature, what about my presentation made you think about this diagnosis? And why I say that's important is because we did bring up about that, like not every time you detect these clones, these PNH clones, are they clinically significant. So what I'd say is, like, just why do you think I have this? Hopefully they told you this at this point, but can you explain to me? The second question I would potentially ask is that question that has come up, is that we do know there's different types or different diseases that can go with PNH, and so I would say, is there any reason to think I may have an issue with my bone marrow, and by that I mean, is there some reason to think that I may have an aplastic anemia? Just because, as so many people on the panel have brought up, the treatment course may look a little bit different. The other question I think is, which people have brought up, is what should I expect? What do I expect for therapy? What's my treatment monitoring going to be? So the good thing about these therapies, so they're written as outpatients, or even home, most of the time, a lot of times at home. But who's going to follow? How will I know if the treatment is working? What am I going to look for on my labs? A lot of centers have these patient portals, which I think are really great. But kind of what number on this portal are we really following here? Or what symptoms should I look out for that would say, like, oh, this isn't this isn't the treatment for me? So how did you get the diagnosis? Do we think that there is any sort of aplastic anemia or other bone marrow condition here? What is my treatment course going to look like, and what exactly are we monitoring for? Would be, I guess, my top 4 questions for a newly diagnosed patient.
Thank you. How often should a PNH patient have a flow cytometry test, and what would be the reasons to have tests ongoing?
Yeah, good question. So sometimes, a lot of times, the monitoring is more from you kind of making treatment decisions. So I get say that I have a specific, every, not like every year, or regimen that I do. I think where the PNH flow is important is when we're talking about like, did the disease evolve? So like when we detect these small clones in a patient who is not being, not on treatment, potentially repeating that frequently or not frequently, but repeating that at certain time points to see if that is expanding, especially if there's a new symptom. But I can't say that that there's like a strict kind of monitoring regimen for that. I think that depends a little bit by provider.
Thank you. Are there any circumstances where a hysterectomy may be recommended for a PNH patient?
Interesting. So for a hysterectomy, I'm trying to think of what might be a scenario. So I wonder if, and of course you can't comment on a certain case, but was perhaps the PNH, the question is always like, is my hemoglobin low because I have PNH? Or is the hemoglobin low because I have I'm also bleeding? So sometimes, although I said like often with PNH, it's going to be this breakdown of cells, sometimes there can be issues with heavy menstrual bleeding as well, not necessarily related to the PNH, but also could be related to you having low platelets from a bone marrow disorder too, could make your periods very heavy. And with heavy, really heavy flow, you could also lose a lot of blood that way. So I'm not sure if that was potentially what the question was for hysterectomy, if it was a different
I think so.
scenario. Okay.
I think so. The next question is, what are your thoughts about the use of Nplate for raising platelets with PNH and the possible association of MDS?
Good. Another great question is these increasing roles. So for those on the call who are less familiar, so we have these what's called TPO receptor agonists. So TPO stands for thrombopoietin, which is the signal that gets sent to the bone marrow to make more platelets. And so that was a great advance. So I treat other patients with another disorder called immune thrombocytopenia. And so being able to drive up the platelet count is very, very helpful. And so in the world of aplastic anemia, one of the medications is L-trombopeg, which is again one of these Nplate, which is romiplostim, are medications that stimulate the bone marrow to make more cells. And so that sounds great, right? That's the whole problem with some of these disorders. And a lot of times it is great, meaning that a lot of times these drugs can really be life-saving by preventing really severe thrombocytopenia. Where we do try to avoid these medications as much as we can would be in patients who already have features of myelodysplastic syndrome, just because that there is thought, and a lot of it is kind of in the lab of kind of stimulating the bone marrow, and perhaps stimulating more selectively cells that can be more likely to form MDS. But I want to make clear that a lot of times these medications, they don't cause that in a lot of people, and I want people to kind of feel reassured that risk is overall a low risk. And so for a lot of people, the benefit of getting the platelet count up and avoiding transfusions kind of outweighs that risk, because it can be very hard if you have severe thrombocytopenia to continue to get transfusions, particularly if you make antibodies to some of the platelet transfusions. So those are therapies that we certainly use, and I think you need to be aware of them, but not kind of be told, not kind of write them off because of that association, because they could really result in meaningful improvement in blood counts.
Well, thank you so much, Dr. Pishko, for sharing your time and your expertise with all of us today. It was a wonderful presentation with lots of great questions and answers. So thank you so much for that. And if you would like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking on replay. You can also view the session by navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question to our Facebook page. Please don't forget to visit our exhibit hall. Our next session will start at approximately 1 o'clock. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our session. Thank you again, Dr. Pishko.